Future presentations will be focused on attribution, quality, cost effectiveness, delivering healthcare professionals, and the last one will be an open forum where we'll be discussing questions. The first section that I will be going over today will be BMI reporting in Alabama Medicaid. First of all, I'll talk about a few statistics related to obesity. Individuals who are obese are 7 to 12 times more likely to develop diabetes. Obese individuals are also at risk for developing coronary artery disease, and their risk for developing coronary artery disease is increased by 80% compared to those with a normal BMI. Also, obese individuals are 64% more likely to suffer ischemic stroke, and childhood obesity is a serious problem in the United States and Alabama, and obesity in children can put them at risk for poor health. The incidence of obesity in the Medicaid population has been very difficult to determine since BMI reporting has been very low by providers in the past. Those 18 and over that have been identified as obese are more likely to have a chronic condition. Childhood obesity is also an area of focus for the ACHN program, and it is one of the 3 quality improvement projects that the networks are required to implement. More details will be provided in a future presentation about quality and how the BMI reporting relates to quality. So, beginning October 1st, 2019, Medicaid will require physicians and physician groups who bill procedure codes 99201 through 99205. These are your new patients, 99211 through 99215, your established patients, and 99241 through 99245, your consultations, to be appended with a BMI diagnosis on the claim, or the claim will deny. This requirement will apply to the following groups: PCPs, the nurse practitioners, and physician assistants related to those groups, PCP groups within a PCP enrollment agreement on file with Medicaid, FQHCs, rural health centers, health departments, teaching facilities, and there's one more that I will add onto this presentation. That's delivering healthcare professionals other than when a recipient is pregnant. If the recipient is pregnant, the delivering healthcare professional will not have to append the BMI to the claim. This is a table that describes the CPT codes I've just gone over, and the ICD-10 codes for children less than 20 years of age. For the children less than 21 years of age, the ICD-10 codes are related to the percentile. For adults, the requirement is related to the actual BMI that starts at 19 or less and ends at 70 or greater for the adult. Now we'll go into referrals. Form 362, this is our current referral form. It has been revised, and this form will be on the website by the end of the day. It may already be posted out there, but it will be under the ACHN tab and providers and then forms. So you should be able to find it out there. If it's not posted right now, it will be posted by the end of the day. There are several important things to remember before we go into a few details about referrals. PCPs will no longer have patient panels, so you won't have to manage patient panels, but social workers and nurses can help you in this ACHN program with your more complex, non-compliant patients and other patients that you have that you feel like need care coordination. PCPs and PCP groups will not need a referral to see a patient, and the nurse practitioners and physician assistants collaborating within the PCP group will also not need a referral to see a recipient. The EPSCT referral process will not end. There have been concerns about patients going from one physician to another, and with us removing this requirement. And if you are aware of this happening when we go into the ACHN program, this is a case when you really would need to make the ACHN aware of the recipient. The ACHN can get the nurse or the social worker to assist in getting the recipient to go to just one PCP. Another thing to remember is that we do not enroll urgent care centers, but we do enroll PCP groups. And if an urgent care center is enrolled as a PCP group, this group must also meet all of the requirements, all of the PCP requirements as outlined in their contract and with Medicaid. PCP referrals will be required for most specialists to receive payment, such as DME, orthopedics, or cardiology. Nurse practitioners or physician assistants collaborating with specialty groups will also require a referral. In the instance when a PCP cannot be identified or the patient has not been attributed to a PCP, the ACHN can provide a billing referral for a specialty, and I'll talk more about that in a few minutes. This slide shows some services that do not require a referral, and some listed in that list are administration of allergy injections, ambulance services, certified emergencies, radiology services, and laboratory services. Some provider types that do not require a referral are county health departments, CRS, children's rehab services, hospitals, independent radiologists, pathologists, and dermatologists. These are just a few of the provider types and the services that would not require a referral. For a complete list of services and provider types that will and will not require a referral, you will need to look at the Provider Billing Manual, Chapter 40, that is coming out, that will be released October 1st. Now we'll talk about the ACHN referral process and for billing purposes only. In certain circumstances, the ACHN may assist a specialist with obtaining a billing referral. In these circumstances, the ACHN must be contacted by the specialist for an ACHN billing referral. An example for when this could occur is when the recipient is not attributed to a PCP and the recipient has been to the emergency room for care, but they have received a referral from the emergency physician to a specialist. In this instance, the ACHN may assist the specialist with the billing referral. The ACHN will use the Form 362 and append for billing purposes only in the space provided under the referral valid for. The ACHN will encourage the recipient to enroll into active care coordination to ensure that the recipient finds a PCP as quickly as possible. Reminders related to referrals. The referral process is very, very similar to the patient first process that we have today, the patient first referral process. A referral is no longer required for PCP to PCP visits. The Referral Form 362 has already been updated and will be posted to the website by the end of today if it hasn't been already. A referral is still required for most specialties and services, and the EPSDT screening process will not change. The referral process for EPSDTs will not change. Updated list of services and provider types that will and will not require referrals will be released by the agency on October 1st, and it will be in Chapter 40 of the billing manual. Now we'll go into understanding new rates and payments. The goals of the ACHN program align for physicians, Medicaid, and the ACHN. Payments have been structured to keep the PCPs whole. Medicaid will pay physicians. The ACHN will not be making payments to physicians. Physicians will no longer receive case management fees, and there will no longer be patient panels. The participation rate payments will be made to PCPs who actively participate with the ACHN. So what does it mean when we say actively participate? Physician groups must first sign an agreement with at least one ACHN to participate and meet the criteria for participation with the ACHN. The criteria include that the PCP must actively work with the ACHN to review recipient care plans. The PCP must participate as needed in the ACHN multidisciplinary care team meetings. The PCP must participate in ACHN initiatives centered around quality measures. The PCP must participate in at least 3 quarterly medical management meetings. One of them can be a webinar. One of these 3 meetings can be a webinar, and they have to participate within a 12-month period. So what is new about this requirement as compared to current health home? Nurse practitioners and physician assistants may attend these meetings for the PCP group. That is what is new. Also, the PCP must review data provided by the ACHN to help achieve regional and state Medicaid goals. I'm going to go over this chart from the bottom up. So providers who are currently eligible for the bump will still be able to receive bump rates if they choose not to participate with the ACHN. But if they choose not to participate, they will not be eligible for participation rates or bonus payments. Going on up the chart, the base fee for service, providers who choose not to participate with the ACHN will continue to get the regular fee for service rate. We fully expect most providers to participate with the ACHN and receive the higher rates. Moving on up the chart is the regional ACHN participation payment and that is the participation rate. The participation rate is an enhanced payment for 15 E&M codes, the same ones that I've talked about earlier, 99201 through 99205, 99211 through 99215, and 99241 through 99245. And those are the participation rate codes. And the participation rate payment will only be made to those physicians who choose to actively participate with the ACHN. Nurse practitioners and physician assistants who collaborate with the PCP who is enrolled will receive 80% of the physician rate on these participation rates. Moving on up the chart are the bonus payment categories. The patient-centered medical home, the cost effectiveness, and the quality metric performance. And payment for all of these is based on the number of patients attributed. So your size of your payment will be based on the number of recipients that you have actually seen and that are attributed to you. This next slide is a chart that I'm going to go over. I'll go over it at the end as well. Patient scenario number 1, PCPs not eligible for bump rates and not participating with the ACHN will receive only those base fee-for-service rates. They will not be receiving the bump rates, the participation rates, or the bonus payments. PCPs not eligible for bump rates and participating with the ACHN will continue to receive their base fee-for-service rates. They will not receive bump rates. They will receive participation rates, and they will receive bonus payments. PCPs eligible for bump rates and not participating with the ACHN, they will not receive the base fee for service because they're receiving the bump rates. They will not receive participation rates, and they will not receive bonus payments. Those PCPs eligible for bump rates and participating with the ACHN will not receive the base fee for service rates. They'll receive the bump rates on those other codes other than the participation rates, and they'll receive the participation rates because on those 15 E&M codes, and they will receive the bonus payments. This slide shows the differences in the bump rates and participation rates. There are some differences that I really would like you to take a look at. For instance, 99203 and 99204, these are your newly established patients or your new patients. There's a difference in the payment of $6.48 for 99203. There's a difference of $10.75 for 99204. Then go down to 99213. There is a difference of $3.83, and then 99214, there's a difference of $7.09. FQHCs, RHCs, and teaching facilities are reimbursed in a different way than other PCPs. Physicians in any of these groups are eligible for bonus payments, but they will not be receiving participation rates. I wanted to make sure that everyone was aware of that before we go on. Next, we'll be talking about the bonus payments, and there is a bonus pool that has been established, and it is in the amount of $15 million annually that will fund these 3 bonus payments. 50% for quality, 45% for cost effectiveness, and 5% for PCMH recognition. But I wanted to also let everybody know that in the beginning, these bonus pool payments will be based on, the size of these payments will be based on your attributed recipients. So next we'll be talking a little bit about patient attribution. More details will be coming out in future webinars, and I believe we're having one next week about attribution. The patient attribution is used in determining the size of the bonus payments. Recipients will not be assigned, but will be attributed to the PCP group level. Recipients will be attributed to the PCP group based on where they received the services. A score will be calculated for each recipient-provider combination. The provider with the highest score for the recipient will be attributed that recipient. More recent claims and preventive visits will receive the higher values in this calculation. Recipients will only be attributed to one PCP group per quarter, and attribution will be updated quarterly. And again, more details will be forthcoming in the next webinar. Patient-centered medical home activities. These payments will be based on attainment of PCMH recognition by the appropriate national organization or the documented progress toward PCMH recognition. Examples of some of these organizations are listed here: the National Committee for Quality Assurance, the NCQA, and the Joint Commission. There may be others out there. You will need to contact Medicaid and make sure that we're aware of the one that you would receive this PCMH recognition through. This will be evaluated annually, and this payment will be made quarterly. You can see on the chart here that you will receive a full payment, and remember, this payment is based on the size of your attributed population in those first 4 quarters, and then starting in quarter 5, it will actually be calculated. And more details will be coming out to the provider groups before we actually start calculating that, to give you more details of how we want to receive that information. Cost effectiveness. I want to reiterate again that the size of the cost effectiveness payments are based on patient attribution. Cost effectiveness is risk adjusted based on different levels of patient acuity within a practice or individual group. It's also compared peer-to-peer. So for at least 5 quarters, ACHN participating groups will receive payments based on the number of recipients attributed during the prior quarterly period. And an entire 1-hour webinar will be focused on cost effectiveness, and also be looking for more information that will be forthcoming about this in the Provider Insider. This is a chart that shows that cost effectiveness will be based on attribution for up to quarter 5, and then it will actually be calculated in quarter 6, which is the winter of 2021. Next, we'll move on to quality metric performance. For the first 7 quarters, PCPs will receive a full quality bonus payment, and beginning summer 2021, the group must achieve annual bonus benchmarks that are determined by the agency. These benchmarks will be posted on the website prior to October 1st. Payments will be based on measures that are relevant to the group and the number of attributed patients, and this payment will also be made quarterly. And you can see on this chart that you will receive a full payment based on the attribution up through quarter 7, and then beginning quarter 8, it will be calculated in summer of 2021. These are the payment dates and the times. The bonus payments will be made quarterly and will start in November 2019, and then at the beginning of the quarter starting in January 2020, the payments will be quarterly based on that month. But the first payment will not begin until November, until the first check write in November. Participation rates will be made every check write. So I would like to go over this ACHN payment scenarios one more time. So PCP scenario number 1, PCPs not eligible for bump rates and not participating with the ACHN will receive a base fee-for-service rate. They will not receive bump rates, participation rates, or bonus payments. Scenario number 2, PCPs not eligible for bump rates and participating with the ACHN will receive fee-for-service rates. They will not receive bump rates. They will receive participation rates and bonus payments. PCPs eligible for bump rates and not participating with the ACHN will not receive the fee-for-service rates. They will receive bump rates. They will not receive participation rates or bonus payments. PCPs eligible for bump rates and participating with the ACHN will not receive fee-for-service rates. They will receive bump rates and participation rates and bonus payments. This chart is an ACHN payment summary chart, and so the one side talks about the patient first ending September 30th, and the other side talks about going to the ACHN. So we know today we have panels. When we go to the ACHN, we will no longer have patient panels. Case management payments are made today to the PCPs that are enrolled with Patient First. In the ACHN, there will be no case management payments made. Today, physicians that are eligible for bump will receive bump. When we go to ACHN, those physicians will receive their bump rates, and they'll also receive the participation rate if they sign up with the ACHN. When we go today, the Patient First program, PMPs do not receive bonus payments. When we get in the future, everyone that qualifies will receive bonus payments with the ACHN. Today, we have the regular fee-for-service for our non-bump providers. When we go to ACHN, we'll still have regular fee-for-service for our non-bump and or the participation rate if the physician qualifies. So now we'll be going to our questions, and we'll go ahead and get started with those questions.
Thank you, Jerry, for that presentation. Before we get started with the questions and the answers, I do want to give a reminder that the link for each of these webinars, as well as the password, is listed on the Medicaid webpage. If you will be sure for future webinars, please visit the website prior to the webinar and click on the link that's provided. It also, if there's any updates to the password for the webinar, it would be listed on the Medicaid website. If you remember, there's a picture or a web slider that comes up on our home page for the webinars. When you click on that, it takes you directly to the document with the links for the webinars. I do apologize if you had any difficulty joining today's webinar. It will be posted I would say within the next 30 minutes of completion of this call, and you'll be able to have the entire presentation along with the recording from the website. Thank you.
All right, we'll begin with some of the questions. First is, will there be an age restriction for the BMI requirement? For example, a patient less than 2 years old will not have a BMI. That is correct. BMI requirements will not be needed for anyone less than 3. Starting at age 3, they will need to have BMI requirements. How does the new referral form differ from the old one? It basically just strips the patient first name and it addresses the ACHN. Jerry, is there anything else?
It does have a place in there for the ACHN to be able to provide that billing referral only.
Will an OBGYN seeing a non-pregnant patient need a referral from the PCP? And the answer is no. As long as it is a primary care to primary care type of care, then there will not be a need for a referral. How will therapy providers obtain a referral under the new system? As long as if it is a type of referral under EPSDT, the EPSDT referral process has not changed, and you would still need an EPSDT referral for that.
Right.
How will we know the patient is doctor shopping, seeing multiple physicians? If you believe that you have a patient who is shopping around, seeing different ones, we encourage you to reach out to the ACHN and check. We are providing all claims history for all of our recipients to each of the ACHNs so that they will be able to see all processed claims. That way, they'll be able to identify and help you work with that patient as well as working counsel that recipient on the importance of having a medical home. If we have a patient first referral that covers past October 1st, will we still be able to use it, or do we need a new referral?
You will still be able to use it.
Okay, so it will still be good. What are the hours and days that the ACHN people will be available to PCPs? The hours of operation for the ACHN are they must stay open Monday through Friday for all, minus all state holidays, and the hours are from 8 to 5. They also will have a phone center where any PCP may call, and again, those hours are also 8 to 5. Is there any way that we can know if the patient had seen any other doctor on the day that they come to see us? Unfortunately, no. All that you would have access to in the panel and all that we here at Medicaid or the ACHN would know is what we have through claims processing. So if a claim has not been submitted and paid, we would not have knowledge that a recipient has seen another provider the same day. Are patient Medicaid numbers changing? No. The Medicaid numbers will stay the same. When will the billing manual be available?
October 1.
Okay. And we're trying to push that out as fast as we can. We do know that a lot of the referral processes and all the information you need from the provider manual, you need to go on and start training your staff. We will try and get that out as soon as we can. We are in the review process now to get it pushed out as fast as we can. As Melanie stated, the PowerPoint has been recorded and will be posted to the website as soon as we can after we end today. You use the word attributed to a PCP. What makes this different from a sign other than that the lists are going away? This is a fundamental shift in the program. Currently, when a recipient joins Patient First, they are physically assigned to a PCP, meaning to receive primary care services, they must go to the PCP that they have been assigned to. That is going away. We have now given the freedom to the recipients, to our patients, so that they can choose to see whichever PCP that they want to. Therefore, when we go to calculate whether a patient has been attributed, it is a historic evaluation of where that recipient has sought their services in the past 2 years. Have they been mainly seeing you, or have they been seeing other providers? Who has been writing the prescriptions for maintenance medications and getting them filled? All of those are type of issues that we go into the calculation of attribution. And we actually will have the whole next webinar on Thursday, September 12th, deals with attribution, so I do encourage you to tune in for that. If the PCP panels are going away, how will specialists know who they'll need to send the referral? Although the panels are going away, we will still be pushing out, and it'll be available on the web portal, the provider that the recipient has been attributed to. So you can start there and go with that, because we will post out who the patient has been attributed to. Do referrals to OD for eye exams require a referral from the PCP? No. Currently under Patient First, that's not required now, and therefore it won't be required in the future. Is the bonus structure available to RHCs? Yes. RHCs and FQHCs will not receive the participation rates, but the bonus payments are open for eligibility to RHCs and FQHCs if they sign a participation agreement and meet the participation requirements. Can the office manager attend the meetings for the PCP, nurse practitioner, or PA? The answer to that is no. The medical management meetings are designed to address medical concerns, practice guidelines, quality initiatives, things like that. And that's why we require that a PCP, nurse practitioner, or a PA from the group to attend those meetings. Do we only need to be with one ACHN for our area? Can patients from other areas see any PCP? Who you participate with is up to you. Patients are assigned to an ACHN based off of their county of residence. Now, patients can see any PCP that they choose to. So if you live along, or your office is along the border of a region, you can sign up with multiple different ACHNs because your patients will be coming from different regions. But it is up to you whether you choose to participate with one or multiple ones. If you do choose to participate with multiple ones, you only have to sign one agreement, though. Why not just have, let's see, will it show what group a patient is attributed to on the Medicaid portal? Yes, it will. There's a question about the PCP referrals. A couple people have missed it. Can you go back and cover that real quick, Jerry?
It's not working. Which one?
Going over referral codes for primary and specialty.
Okay. These are things that you have to remember. A referral is no longer required for PCP to PCP visits. The Referral Form 362 will be updated if I believe it's been updated. It has been updated, and it should be on the website by close of business today if it's not already out there. A referral is still required for most specialties and the EPSDT screenings. Those referrals will not change at all. There will be updated list of services and provider types that will not require a referral, and those that will require a referral, and that will be released in our October 1st provider manual in Chapter 40. Okay.
All right, thank you. We have another question. Do we need to contact Medicaid to let them know if we participate within CQA? I'm going to turn that, yes. Yes, you will have an annual attestation to Medicaid if you have received or if you're in process to attaining NCQA PCMH recognition. If we see a patient not knowing that the patient has been seen the same day and they bill first, and our claim is denied because of that, can we bill out to the patient? It would be the same as is today. If you've not given them notice beforehand and you've not checked to see whether they have eligibility or not and let the patient know, you cannot do that now. Again, it goes back to even today, you can only see any claims that have been processed now. You can only see what we have seen on our side. So you will not know if a recipient has gone to multiple doctors on the same day. Will we be able to print out the slides? Yes, we will be posting them in a PDF format so that we're happy for you to print them and share them with your group. Will a specialist have to include a BMI diagnosis on the claim? No. Will the bonus and participation payment be listed as such on our summary or on the remit, or as it is now for capitation payment?
Those will be paid through an invoice, so it'll be a lump sum, and you'll be able to see it on your remittance advice.
Okay. So it will show up on your remittance as a lump sum. And yes, we did record this presentation. Will each PCP group be assigned an ACHN worker to be on site daily? No, but as you agree and you sign your participation agreement with the ACHNs, that is something we encourage you to have a conversation with the ACHN. There are some providers that will probably have an embedded care coordinator, but it is up to each ACHN to do their own staffing and where they will locate them. If you are a larger practice with a lot of Medicaid recipients, they might be more open to it, but again, that is a decision between the ACHN and you. All right, and Dr. Moon, do you want to turn it over to you for a second?
Yes, thank you, Drew. I just want to give you a chance to check on a few more questions, but I did want to make a few points along the way just to clarify a few issues. The question was asked earlier about would an OB require a referral from a PCP to be seen. I want to clarify that a bit. If the OB is functioning as a PCP, meaning not just that they consider themselves that in general, but meaning they have signed a PCP agreement and they're fulfilling the requirements of the PCP agreement, then no, there would not have to be a referral from the PCP to the OB. However, if the OB is not functioning as a PCP, then a referral is required, especially when you think about things like GYN services, et cetera. I also wanted to go back and cover the issue about the specialist needing a referral from the PCP. The specialist needs the referral from a PCP. It does not necessarily have to be from the PCP where the individual is attributed. So keep that in mind. Now, ideally, it would be so because the individual recipient would be receiving their care from a single PCP, and it'd be important to have that communication. That's not always true, doesn't always exist, but the preference would be certainly that they would go back to the attributed PCP. However, what the specialist needs is a referral from a PCP. I did want to revisit one more thing, and then I'll turn it back over to Drew, and that was the question that just came up about would a care coordinator be on site in every practice? Please remember that is a decision for the ACHN to make. They have to manage the resources that they have in an efficient, effective way. Obviously, if you've got a practice that has 10,000 Medicaid recipients, that might make sense for the ACHN to put someone there. If you have 5 Medicaid recipients that are attributed to you, it might not make sense. So it'll be a decision. But I would encourage you to interact with your primary care physicians that are on the boards of the ACHNs and also the executive directors of the ACHNs around questions and concerns you have about this particular question. So I'm going to turn it back over to Drew.
Okay. Let's see, there's a couple new questions came in. If the patient resides in a different ACHN region than the one I'm enrolled with, what ACHN will need to contact for referral if the patient resides in another ACHN? I'm a little confused by that question. If the referral does not reflect on the ACHN, if you are a primary care provider and you were sending that patient to a specialist, you would send the referral. If you're a specialist and you are trying to seek a referral from a primary care provider, you would just, you would ask that patient who their primary care provider is. You can check the portal to see if there is a provider attributed to them, or you could, if neither are available and you're trying to find who the primary care provider is, you can check with the ACHN where that recipient resides. So, for example, if the recipient lives in a county outside Jefferson and Shelby, but you have a practice in Jefferson and Shelby, you would call the ACHN where that recipient lives and say, I have X patient, I'm trying to find out who their primary care provider is, they don't seem to have one, and I need a referral. That's where the ACHN can assist you. But the referral is only from provider to provider, from primary care to specialist, not primary to primary. If you're not currently taking new patients, will you be required to see patients that you have never seen? Will you still receive incentive money if you're not taking any new patients and only continue to see the patients that were assigned to us before the change? Well, the assignments go away, and you can continue to choose to whether you want to take new patients or not, but that is something you will have to let the recipients know as they try and schedule an appointment with you. You will only receive incentive money if you sign up with an ACHN and are a participating provider. That makes you eligible. How much you will receive in incentive money is based on the recipients that are attributed to you. So the more patients that you see and are attributed to you will dictate the size of the incentive money you will receive. Does non-participation in the ACHN affect general Medicaid participation? No. The only difference between participation with an ACHN versus general Medicaid participation is that if you do not participate with the ACHN, you get the base fee-for-service rates. What about non-emergent emergency room visits? Will referrals still be required?
For those certified emergencies?
No, non-emergent.
Okay, non-emergency, yes.
What if we are listed as a patient's PCP but have never seen the patient? Are we still required to give a referral? Moving forward, that would not be the case because attribution is determined based off of historic services. So if you've never seen the patient, there's no way for that patient to be attributed to you, except in the sole instance if someone in your group has seen that patient. And because all of attribution and all the calculations are done at the group level, if someone in your group's practice has seen that patient, then that patient could be attributed to your group. Will there be a fee schedule change for therapy codes? At this time, it is not the intention of the agency to change any of the additional fee schedules. What proof does the ACHN require to verify PCMH is in process? The proof would not go to the ACHN but to Medicaid.
Those details will be released. The information that we'll need from you will be released prior to when we actually.
Before we start counting.
Yes,
so within the
right.
next year.
Within the next year.
As a specialist, not a PCP, is our practice eligible for the bonus or bump payments? Bonus payments you are not eligible for as a specialist unless you sign up and participate as a participating PCP. Bump payments, if you currently qualify for bump, you will still be eligible for bump, but you will still have to do the annual attestation and requirements that are currently required now.
And you would not receive participation rates.
Correct.
As a specialist unless you had signed a PCP agreement and met the requirements of the PCP agreement. Let me address a couple of other things just to add to, and then I'll go back to Drew again. I do want to go back to this issue about which ACHN do you contact regarding a recipient. The recipient is assigned to the ACHN based on where they live at. So their care coordination, if a recipient comes from another region to see you and they need care coordination, the entity responsible for their care coordination is the ACHN that covers the region where the recipient lives. That also means that if a specialist needs a referral, and for whatever reason this particular recipient has not been attributed to any primary care physician and you need the help of an ACHN to get a referral, then you need to go back to the ACHN based on the recipient's residence. Just a couple of other points. This idea about how many patients are assigned to you versus attributed. Remember, again, attribution. It's based on actually things being done and folks being attributed to you. Again, there will be an in-depth webinar about that next week at this time. But the incentives that you receive are going to be based on the number of recipients attributed to you. So someone asked the question about, is Medicaid or someone else going to require me to see a certain number of patients? The answer is no. but they're also not going to limit the number of patients. In the past, we've had limits on the panels. There is no limit on the attribution. If you can attract more patients, well, good on you. Attract them. Attract however many you want to attract. But no one is forcing you to see folks. And that's true certainly for most of the other insurances that you deal with out there. So, and the last thing I'll reemphasize before turning it back over to Drew is the question about if you've never seen a patient, would they be attributed to you? Would you have to worry about referrals? As Drew said, no, they're not going to be attributed to you if you've never seen them. You did raise the issue about the group. Remember, attribution is at the group level. So if someone is attributed to your group, then they're attributed to your group. So that will be true throughout, and the bonuses and whatnot are all based at the group level. So I'll turn it back over to Drew.
Will the BMI diagnosis have to be on every claim for the patient or once per year for each patient?
Everyone.
It's every claim for every E&M code. Jerry, I'm going to turn this one to you. Recipient notice letter dated September 1st, 2019 from Medicaid states in line 2, you may go to any primary care doctor or OBGYN as long as the doctor will take your Medicaid. Actually, the OBGYN has to be signed up as a PCP, otherwise a referral will be required, ?
The OBGYN does not have to be signed up as a PCP because the recipient can still go to any OBGYN or any PCP they choose.
The OBGYN would need a referral.
Yes, but the OBGYN would need a referral.
So that you are correct. Will you still get a list of your patients from Medicaid? You will still receive a quarterly report, but it will not be those who have been assigned to you, but those who have been attributed to you. And that first attribution report will come out at the end of September, 1st of October. So later this month, at the end of this month, 1st of next month, you will receive a report of who we have historically calculated attribution to you. When we verify patients' Medicaid eligibility, will it show what ACHN the person is enrolled with on the portal? Yes, it will still show. Just like you currently see whether they're enrolled with a health home or not, as of October 1, it will now show what ACHN they are enrolled with. I am in the Northeast, patient lives in the Northwest and has been seeing me as a patient. Is this covered as a PCP? Yes. The patient has a choice to see whoever they want to for their PCP. When billing, should chronic disease always been billed with every office visit?
We would encourage you to do that. It's certainly not required, but I would encourage you to do that just because it helps build the acuity ratings associated with your patients, assuming they're applicable diagnoses for that individual. Coding, the diseases that are active, that are present, are certainly important.
How will you know who to get the referral from for the non-emergent ER visit?
It's the same issue.
It would still be the same of you would need to contact their PCP, or you can check the portal to see who they have been attributed to. Where do we find a list of all the ACHNs? We are only signed up with one, and I'm wondering if we have a patient present in our practice that is attributed to another ACHN that we have not signed up with. On the Medicaid website, we have actually completely redesigned it, and there's a whole special section for ACHN. It is under provider. You go to ACHN, then go to ACHN provider, and about the 4th or 5th link down, there is a map that lists all of the ACHNs, a region, and their organizations, their point of contact, their phone number, and their email address. Will we use provider individual NPI or a group NPI numbers on the referral forms?
Does not matter.
It does not matter what you use.
Group or individual?
Will claims go through Alabama Medicaid, or do we need to add attention ACHN to claims? All claims will continue to go to Medicaid. Medicaid will pay the claims. ACHN will not provide any providers. If the PCP is listed on the portal as a PCP who has never seen the patient nor anyone in the group, what is the easiest way to get the referral? After October 1, you should not have any PCP listed on the portal of someone who has never seen a patient nor anyone in their group. they would be attributed to someone else. Are the bump forms and applications going away, or will a provider need to complete both the current bump application and the ACHN application? That is correct. The bump forms are still in the same location, same requirements and everything. Yes, I'm getting a yes for that. Will we be able to dismiss a patient if needed? Yes, that process will still be okay. Will the patients will the EOPs come from Medicaid or ACHN? They will come from Medicaid. Can attribution reports show phone numbers? I am unsure whether we've included phone numbers or not. We historically don't report out phone numbers of our recipients because they have not historically been very accurate on our side.
We can take that as a note for the attribution presentation next week.
Oh, wait, you're saying what? Does or does not? Okay, currently the patient first report where you get your panel assignments does not list that. What are the patients that have been dismissed by our group? Will they be attributed to us? Yes, they could be still be attributed to you because of historic utilization, but over time, if you have stopped seeing them and someone else has seen them, the next quarter's run would probably remove them from them, as long as they are starting to see another provider. But until they start seeing and have claims coming in from another provider or provider group, they would still be attributed to you.
That's true, but just remember again, the attribution does not restrict them. If you discharge them, they can start attending somewhere else.
Are patients still limited to 14 visits per year? That is correct. Would attributed PCP be identified on the eligibility file as well as on the web portal? We do know that they will be identified on the web portal. I am not sure on the eligibility file. Please forgive the duplicate question, but the BMI only needs to be on an E&M or EPSD visit. Does it need to be on a sick claim, example of a fever?
Yes.
Yes. Can we bill a patient directly if they run out of visits for the year or for an EPSDD screening if the portal has not been updated prior to seeing the patient?
That would go back to the typical Medicaid rules about informing the patient ahead of time of such a situation as that. You would have to inform them ahead of time, have them sign to agree to do that in order to be able to do that.
Just for clarification, will an OBGYN require a referral from PCP for office visits?
Yes.
Yes. Can a DHCP limit the number of OBs we take? I think you mean, can a DHCP limit the number of maternity patients they take? Yes, that they can still limit that.
And that would be a discussion between you and the ACHN that you work with.
Correct. And that is all of the questions. Whoop, just one popped up. If a specialist has an old patient first EPSDT referral that is still valid because the EPSDT referral hasn't expired, can they continue to use this referral? Yes, we can. You can still use that referral. And that is the final question we have. Melanie?
Thank you once again for your time today. We appreciate you spending the last hour with us. We hope this information has been helpful. We will be downloading this webinar and the recording, and we will be posting the slides as well as this presentation that's been recorded on our website. To get to the website link, you'll go to www.medicaid.alabama.gov. Once you get there, you click on the ACHN tab, and then you click on Providers under the ACHN tab. You'll see the past webinars posted there as well as today's webinar. And if you need to get to the link of future webinars, you can click on the web slider from the home page. Thank you once again, and have a great day.